Buonasera a tutti e benvenuti a questo live webinar. Io sono Roberta Martegliano di REGEDENT Italia e prima di iniziare questo webinar vi spiego un po' le impostazioni perché è un webinar internazionale e quindi voi potete scegliere la lingua che potete sentire, cioè la lingua italiana e la lingua inglese. Per poter scegliere, vedete nella barra, c'è la possibilità nell'icona del mondo, c'è anche scritto interpretariato e andando a cliccare potete scegliere la lingua se italiana oppure se inglese. In inglese sentirete la relatrice parlare. A REGEDENT d'Italia noi siamo molto contenti di aver con noi la dottoressa Kristina Bertl. L'abbiamo voluta in questo webinar proprio per parlare del trattamento non chirurgico secondo il protocollo Clean&Seal di tasche residue. E Kristina Bertl è parodontologa presso la Svezia, in Svezia, sia nella sua clinica e anche fa parte del Dipartimento di Parodontologia dell'Università di Vienna, la Sigmund Freud. Ha pubblicato più di 100 articoli scientifici, quindi su riviste impattanti. Fa parte della Società di Parodontologia a Vienna, in Svezia, e della Società di Implantologia. E inoltre ha fatto parte dal 2022 al 2025 del membro del Consiglio della Società Europea di Parodontologia e è anche stata ambassador per quanto riguarda il congresso che si è tenuto a Vienna all'Europeo 11. Ora, tutte le domande le lasceremo alla fine, quindi sarà una mezz'oretta in cui farà vedere la sua presentazione e gli ultimi 10 minuti è sempre dedicato a tutte le domande che potete mettere nel box. Ora lascio la parola a Cristina, alla dottoressa Kristina Bertl. Cristina, I leave you the stage and you can share the screen.
Thank you, Roberta. And thanks for the kind invitation to this webinar. I shared now my screen. I hope everyone can see it.
Yes, it's okay.
Perfect. So then, welcome also from my side to this evening webinar. And we hope that we have chosen a topic which will be of interest for you and that you can take something with you from today's webinar. And the topic is about how we can maybe prevent surgery in periodontitis patients and how biologics can help us here. So we want to discuss a little bit, or if we think about treating periodontitis, we know that we have the S3 guidelines from the European Federation of Periodontology, which give us a very good pathway and a very good heading how to treat our periodontitis patients. But we would also like to discuss how hyaluronic acid is blending into these treatment guidelines and where we maybe can use hyaluronic acid additionally to improve our outcomes. So if we think very shortly about the S3 guidelines and the treatment sequence of periodontitis patients, we know that the first step should always be the preparation of our patients, meaning we really have to instruct them how they can improve mostly their oral hygiene, so how they can improve the brushing, what kind of interdental devices they should use, which interdental brushes, and we have to reduce the risk factors like, for example, smoking, before we go in step 2 to the classic periodontal treatments, or the cause-related non-surgical periodontal therapy, which is followed by step 3. In step 3, we evaluate our results from step 2. It's also the step what we want to concentrate on in this webinar. And if we finally succeed and have get a good result, the patients continue in supportive periodontal care. But I think one important step here is always that we have to keep in mind when treating periodontitis patients, and I usually say that to my patients, that this treatment of periodontitis is a team approach. And I always say it's about 10% we do in the dental office, but the patient is a big part, especially in the long term. So the patient has really to understand that he has to be a part of this treatment process. But now let's jump quickly into step 2. And as I said before, step 2 is the course-related therapy. So it is the subgingival debridement or instrumentation. And this can be done with ultrasonic devices or with hand instruments or a combination of it. And we know that we get approximately the same results. But what are now the results? What can we expect after approximately 6 months after the subgingival instrumentation? On average, we can expect a probing pocket depth reduction of about 1.5 millimeters. But if we look, for example, only at the initially deeper sites, so pockets which have been before treatment above 6 millimeters, we can already achieve on average about 2.5 to 3 millimeters of probing pocket depth reduction. We can get quite a good reduction in bleeding on probing, and that's always the number which shows me how effective the subgingival instrumentation, so the purely mechanical cleaning can be, is we get actually a closed pocket in 3 out of 4 sites. So we can really solve a lot of problems already in step 2 just with the subgingival instrumentation. But on the same side, this leaves us with about 25% of residual pockets. And we know very well from the literature that residual pockets on the long term increase the risk of losing more teeth. So we would like to avoid these residual pockets. And that is where step 3 steps in. And in step 3, we have actually 2 possibilities. We can either do a re-instrumentation, maybe with adjuncts, and that we will talk more within this webinar, or we have also the possibility to go further with a surgical approach. But we also know, if we think about the surgical approach, that we sometimes have patients, like this one, for example, who just really get scared by the idea of doing a surgical intervention. And sometimes we might also think ourselves, okay, it's just 1 or 2 sides, can't we do something else than taking the blade? And sometimes we might also have some, at least relative contraindications for surgery. We would like, for some medical reasons, to avoid the surgical intervention. So we will focus now on the re-instrumentation in the 3rd step. And if we think about using also adjunctive measures in addition to the re-instrumentation, we always say, or one says from the scientific side, that if any adjunct can, on the average, give us an advantage of 0.5 millimeters or more, we know that is not only maybe statistically significant, but we also know that really gives a clinical benefit to our patients. So that is a little bit the cutoff, if we look at studies, to decide, okay, is this adjunct of clinical relevance or maybe not? So that's everything above 0.5 gives our patient, or can give our patients really a benefit. If we go now once more back to the S3 guidelines and look what the guidelines, or which adjunctive measures the guidelines recommend, then there have been investigated quite a lot, from laser and photodynamic therapy, über locally delivered antimicrobials, but basically only 2 are suggested by the guidelines. And that is the locally administered sustained release chlorhexidine, and it's the locally administered sustained release antibiotics. Those 2 are the only 2 ones which are really suggested by the guidelines, where we can base our decision on scientific evidence. But let's ask now the question, what was actually missing in the guidelines? And that is also the reason why you're maybe watching this webinar today, because what was missing in the guidelines were products with hyaluronic acid. So this was not included, it was not evaluated in the guidelines. What is now hyaluronic acid? Hyaluronic acid has very many positive properties. So for example, it is known that it's bacteriostatic, it has an anti-inflammatory aspect, it is pro-angiogenetic, and then maybe the last 2 points are the ones which for us are most important. It's promoting the wound healing, and it has also been shown with histological studies that it can promote the periodontal regeneration. So it has become quite a big topic, I would say, now in the last 10, 15 years within dentistry, and it has been a lot talking about it. So how can it look like now to work with hyaluronic acid? It could be, for example, a case like this. A patient who has received the non-surgical debridement or instrumentation, so a patient who has received and finished the step 2, but still has now in this example a pocket of 5 millimeters with bleeding on probing on the mesial aspect of the tooth of the second molar in the lower left. So if one thinks now about re-instrumentation, one of course has to do the mechanical re-instrumentation. Again, it can be done with ultrasonic devices, it can be done with hand instruments. And then the idea would be to use a gel containing hyaluronic acid, which can be applied subgingival, but also supragingival. Then maybe one can also, depending on for which product one is deciding, can also use a gel or recommend the patient to use the gel on an interdental brush to apply it daily. And in best case, the patient comes back for the next supportive treatment, has only 4 millimeters of a pocket and no bleeding on probing. Now it's always easy to show one single case and say something is functioning. But of course, we would like to know what is the literature actually saying about it. And we have been starting to work with hyaluronic acid now quite some years back. And we started there with a systematic review where we were assessing what is known about products with hyaluronic acid in the treatment of periodontitis patients. As I said, that is now quite some years back, and at that time point we could identify 10 studies, but these 10 studies were using 6 different products. These products were used once per day or maybe up to 5 times per day. So in the whole study period, maybe only once or 60 times they were applied supragingival or subgingival or both. So it was quite a mixture of different products. So it was very difficult for us to make any meta-analysis to combine somehow the data. So we basically could only give a descriptive overview. And if we look into some of the results, we can see that actually in all of the studies, the test group where a product with hyaluronic acid was used was about up to 20% better regarding bleeding on probing, and the probing pocket depth was reduced more compared to the control group for about 0.2 up to 0.9 millimeters. And if we put it now in relation to what I have told you before, every product which gives us a benefit on the average of more than 0.5 millimeter is assumed to really give us a clinical benefit to our patients. So we are somewhere there in the range. But as I said in the beginning, this systematic overview is now already a few years old, and there are quite some new studies and also a new concept. The new concept is what I would like to present you today and how it is functioning, and that is the clean and seal concept. What is now the clean and seal concept? Clean and seal is basically a combination of 2 products, of a gel to improve the cleaning and the debridement, and a gel to improve the healing outcome. Let's start with the cleaning part. The cleaning part, the Perisolve, is natrium hypochlorite or sodium hypochlorite, and it is mixed with amino acids, and then it's about 0.5% sodium hypochlorite after mixing it. And this gel should be applied into the pocket, and then you should leave it there for about 60 seconds before you start with the subgingival re-instrumentation. And then this step should be repeated 2-3 times. And it's important to know if you're planning to use Perisolve, you should always, because as I said, sodium hypochlorite is mixed with the amino acid solution, and this mixing should be done actually directly before you start the treatment, because it's known that after about 20 minutes it starts to lose slowly the effect. So it's for you important in the clinic. You shouldn't check in the morning, okay, how many patients do I want to treat today with Clean&Seal and then prepare everything. You should just really mix it prior when the patient is already sitting in the chair, we can say like that. As I said, this step of applying Perisolve into the pocket, letting have an effect there for about 60 seconds, and then doing the mechanical instrumentation should be repeated 2-3 times, and then you can rinse the pocket, either with the ultrasonic device or you rinse it with saline solution. And then, after this cleaning step, the second product comes into the place, and that is cross-linked hyaluronic acid, the HYADENT BG. And this is basically just applied into the pocket, and then you will immediately see the effect of hyaluronic acid because it basically stabilizes the blood clot and gives quite a good stability and quite good pre-requirements for a good healing. And then basically the patient can go home. Then again, maybe a useful tip how you can use it effectively in the clinic. So for example, we always store, because if you get the HYADENT, it has 1.2 milliliters of gel, and that is actually quite a lot. And we always keep the same ampoule for the same patient in the fridge. You can do that at least up to 3 months, or basically until the date when the product would be expire, so that you can use it for the same patient at the next supportive treatment again. That makes it, of course, also from a financial aspect for the patient better. How can it look like now in the clinic? Let's look at the case. And again, this patient has already received step 1 and step 2 therapy, and we are already in step 3. But we still have the 6 millimeter pockets on the mesial aspect of the upper left canine. And it also has some bleeding. So we apply first the Perisolve and let it be there for 60 seconds. Then we do the re-instrumentation. I most of the times do the first round with the ultrasonic device, then I reapply the Perisolve, let it again be there for 60 seconds, and then I redebride with the hand instruments, recur it. So this step is repeated 2 to 3 times. And then, after rinsing, you just apply the HYADENT. And then now on this picture, you can already see what I described before, that the HYADENT really stabilizes the blood clot, and you can see this fibrin network already getting quite a good blood clot stability. And then in best case, like in this patient, she came back already after 6 weeks, and you can see a clear improvement in the pocket. We had 6 millimeters before, and we have been down to 3 to 4 millimeters and no bleeding on probing. But then again, it's always easy to show one single case. So I would like to show you a little bit the scientific evidence behind this concept. And there are quite some nice studies which have investigated the effect of this Clean&Seal concept within step 2 therapy. So we start first with step 2 and then we come back to step 3 again. And there is one RCT where they have been comparing in the control group scaling and root planing versus scaling and root planing with Clean&Seal in the test group. They had about 50 patients untreated periodontitis, so step 2 therapy, and they followed them up for 6 months. If we jump now into the results, what can we see in the comparison between the test and the control group? And if we look at the probing pocket depth reduction, we can see quite a big difference. It was about 1.8 millimeter in the control group. And that's also about the value, what I told you before, what one can expect from a well-performed subgingival instrumentation. So the control group actually had a good result. But the test group, which was treated with the Clean&Seal, or additionally with the Clean&Seal concept, had up to almost 3 millimeters probing pocket depth reduction. So more than 1 millimeter difference. And that is clearly beyond this cutoff value, what I told you before, with 0.5 millimeters. Similar for the clinical attachment level again 1 millimeter in favor of the Clean&Seal concept, much higher reduction of bleeding and probing, And that is a parameter which is quite important for our patients. Much lower number, only 1/3 of the sites which still had deep pockets after the step 2 therapy, because that means there's less need of further treatment in step 3. So altogether, quite a big difference in favor of the Clean&Seal concept. And let's look at the second study, which I think is a quite important study because it's one of the very few histological studies on non-surgical periodontitis treatment. So what was done here? It is a preclinical trial with dogs, and periodontal defects have been created and quantified, and then some of the teeth got the regular subgingival instrumentation, while the other teeth got the subgingival instrumentation with the Clean&Seal, as I explained it to you before. And if we jump now again directly into the results and look very shortly into the histology. I don't want to go now in detail, but I just want to show you the difference. We have now on the left side a tooth of the control group, and on the right side a tooth of the test group. And the first black line indicates where the bottom of the defect has been prior to treatment, while the second black line indicates where the cement-enamel junction is. The blue line indicates how much bone and periodontal regeneration was achieved in the control tooth. But then you can see with the pink line quite a difference in the height of periodontal regeneration in the test group. And if one puts that now into numbers, one can see, for example, if we look into new cementum and new attachments, really periodontal regeneration, you can see that the values are about 3 times higher in the test group, which got additionally the Clean&Seal treatment. And also the new bone formation is almost 1 millimeter higher in the test group. And that is actually quite impressive results regarding the numbers. But as I said, that was step 2, and actually would like to know more. What can we do in step 3? So what can we do with residual pockets? Or what can we do with pockets which maybe pop up again in step 4 during supportive periodontal care? And what does the literature tells us about hyaluronic acid, specifically in step 3 and in step 4 of periodontal therapy? Again, there have been some studies accumulating on this topic. And one of the studies is a study which we actually performed in Sweden, but we used a different product. We used a non-gauze-linked hyaluronic acid product. And we wanted to see what can be the clinical benefit of this product. It was also an RCT. We compared scaling and root planing versus scaling and root planing with this hyaluronic acid product, with a gel. We had almost 60 patients and we followed them up for 1 year. So we identified the residual pockets after the step 2 therapy. We did the mechanical reinstrumentation, and then we applied this non-gauze-linked hyaluronic acid subgingivally, and we instructed the patients to also apply it at home for 3 months with their intent brushes. The feedback what we got from the patients that it's quite easy to apply. Statistically, we could see some advantages for the hyaluronic acid, and we could see that the group with the hyaluronic acid required less often any reinstrumentation during the 12 years and had a higher pocket closure rate at 12 months, but not, as we were marginal in statistical significance. And there's a similar study with the HyaDent PG, which is a gauze-linked hyaluronic acid. And then again, they got quite similar results of us. So they also could show quite a good tendency for advantages of the test group, but also lacked a little bit the statistical significance. So both studies here used just hyaluronic acid. And that maybe brings us back to the concept what I presented to you before. And that means to combine the hyaluronic acid with the perisolves in order to optimize the debridement and to optimize the removal of the granulation tissue. And the other 2 studies which are available on that have been using the Clean&Seal concept in step 3 and step 4 of the therapy. One of them was a retrospective analysis with about 30 patients. And the patients, again, were already going supportive periodontal care, but they had some residual pockets. And then they were treated with the Perisolve, as I explained it to you before. Let the Perisolve there for 60 seconds, do the redebridement, repeat the process, rinse it, and then apply the hyaluronic acid. And they could, in this basically retrospective case series, achieve quite nice results. So the overall pocket depth reduction was exceeding 2 millimeters. They got quite a nice reduction in the bleeding and bulbing, and a pocket closure rate of these residual pockets, so of the pockets which were already treated before but not successfully, so in the second round, of about 25%. But the nice thing is that there's now also an RCT available on this indication. So on the indication Clean&Seal in residual pockets. And again, we have two groups. The one just receiving the re-instrumentation and the other one, the re-instrumentation with the Clean&Seal. It's about, again, 55 patients. And all the patients already after the second step, so in step 3. And they followed the patients up for about 9 months. If you look now into the results, and if you look now first into bulbing pocket depth reduction and bleeding on bulbing, we cannot see a big difference between the groups. But the interesting part was if we look into clinical attachment level gain, because there we can see that the two lines, where one is representing, the red one is representing the control group and the blue one is representing the test group with the Clean&Seal, we can see quite a reduction in the clinical attachment level, so more clinical attachment level gain in the group with Clean&Seal, and the difference was about 0.8 millimeters. So again, clearly above this cutoff, what I told you in the beginning, of 0.5 millimeters. And that also resulted in less recession after therapy. So the control group got much more recession after the therapy compared to the test group. But again, the part which, in my opinion, was most interesting to see in this study is if we split up now the pockets depending on how they have been prior to treatment. So have these residual pockets been between 4 and 5, 6 and 7, or 8 millimeters and higher? And if we look now into the pocket closure rate, depending on the severity prior to treatment. And then we can see, if we look at the shallow pockets, the pocket closure rate is in both groups quite high, more than 90%. If we look into the moderate pockets with about 6 to 7 millimeters, we can see that it starts to separate a little bit with a slightly higher pocket closure rate in the test group with Clean&Seal. But if we look now into the really deep pockets with 8 millimeters or more, we can see a clear difference between the control and the test group. And the pocket closure rate was 2 times higher in the test group compared to the re-instrumentation only. And that's, for the patients, quite a difference, because that means that they do not need any additional, maybe surgical step. So if we want to summarize that now, what is the available evidence in step 3 and 4 on using hyaluronic acid? Then we had those two studies which used only a hyaluronic acid product. The first, the one which we did in Sweden, which was a non-cross-linked hyaluronic acid. There we could see some advantages in favor of the hyaluronic acid, and we had more often a pocket closure rate, but it was marginally significant. Then we had this one study where HyAdent PG, a cross-linked hyaluronic acid, was used, which showed tendencies for better results. And I was saying now more often cross-linked, non-cross-linked. What is basically the idea behind it, or why is it discussed that maybe cross-linked could be better than non-cross-linked? The big advantage of a cross-linked hyaluronic acid is that it's supposed to stay longer in the pocket, so it's not so fast resolved, and is supposed to have a longer effect and give more stability to the blood clot. And then, if we combine it even with the Perisolve, with the sodium hypochlorite, we had this case series with quite a nice additional reduction with the re-instrumentation. And we had this RCT, which I was showing you in the end, which has shown a higher clinical or a significantly higher clinical attachment level gain in favor of the clean and seal concept, and combined with less gingival recession, improved pocket closure rate in severe sites. So let's finish with a case. And this is again a case which was already, this patient has received step 1, step 2 therapy. He has received step 3 therapy. He even has received surgery already in this area. And then he was actually going and coming regularly for supportive periodontal care. But at one of these appointments, he came back in a situation as you can see him now. Suddenly again, pus in this area, it is bleeding clearly, he has 5 to 6 millimeter pockets again. And then, of course, as the patient had received surgery before there already, he was not very motivated to undergo again a surgical treatment. So we said, okay, let's try it with the clean and seal concept. So you can see here the situation in the beginning, how he popped up at this one supportive periodontal care appointment with 5 to 6 millimeter pockets. We put the perisolve, we let it there for about 60 seconds. We re-instrumented the site and we repeated this step 2 to 3 times. We rinsed the pocket and we applied the hyaluronic acid, and then the patient can go home. Then the patient came back after 2 to 3 months for for the next supportive periodontal care. And you can see already a clear improvement. There is no separation anymore. There's hardly any bleeding, but you can still see the gingiva is not really tight and it's still a little bit loose. So at that time point, we decided to make a second round with the clean and seal. So we applied again the perisolve, re-instrumented, and we applied the HYADENT. And for example, in this case, we just have saved the same ampoule which we have used for him 3 months before. We took it out again, so the patient does not need to pay for the second round for another ampoule. We apply that and send the patient back home and see him again after 2 to 3 months for the next supportive periodontal care. And now you can see a really nice result. You can see a strong and tight gingiva. We have pockets of only 2 to 3 millimeters. We have no separation and no bleeding. And that was basically achieved just with these 2 rounds of re-instrumentation with the clean and seal concept. So on the one side, it can show you that you can achieve, even in, let's say, severely infected residual sites, quite a nice result. On the other hand, it also shows you that sometimes you maybe need to do 2 rounds of it. So many sites you can solve with 1 round, but sometimes you also maybe need 2 rounds. And then you might sometimes also have sites which still do not heal with the non-surgical approach. And then I would now in the end like to show you one case, what one can do in the surgical intervention and whether one can use hyaluronic acid there again. So we jump back now to this slide, what we have seen in the beginning, the step 3 therapy. And we said in step 3, we can either do a re-instrumentation with the adjuncts, what we have been discussing now, but one can also consider a surgical approach. And how can such a surgical approach look like now with HYADENT PG? This is a patient you can see here on the canine, on the mesial aspect. He had, after step 2 therapy, still 8 millimeter pockets with bleeding. But if you look on the X-ray, we can also see this deep vertical defect, which was basically the reason why this site also could not heal just with the non-surgical therapy. So we decided here to go further with a surgical intervention. But we want to minimize, of course, the extent of the intervention, so we use a minimally invasive approach. It's the entire papilla preservation approach, where one makes a releasing incision on the opposite side of the affected papilla. Then one is tunneling in the tissue and below the papilla to get an access to the defect. Then, of course, one is debriding the defect. But then you can also see the simplicity of using hyaluronic acid in such an approach, because basically you make the flap with a minimally invasive incision design, you debride the site, And then you do not need to prepare the root surface somehow. You do not need to use any ADTA or anything. You just apply the hyaluronic into the defect, and you can see immediately again how nicely the blood clot is stabilized. And then you put some stitches. Then after 6 months, you can see a very nice outcome. From these 8mm pockets, we are down to 3mm pockets. And the nice thing was also the bone healing after only 6 months. So if you compare now on the left side, the situation after 6 months after surgery, compared to the right side with the baseline. And we just used the gel. We did not put there any bone substitutes or anything. So that is really just the patient's own bone, which filled the defect again. And the patient was just here actually now 2 days ago for the 18-month checkup. And he is still as nicely as he has been after 6 months. So if I summarize this now, hyaluronic acid is a naturally occurring substance which is many parts of our body. So it is a natural substance. The idea of the sodium hypochlorite of Perisolve is to improve the removal of the biofilm and of the granulation tissue. And then it is combined with the higher than PG, which is gauze-linked hyaluronic acid, and which has the idea to improve the periodontal healing. And what do we know from a scientific point of view? For the non-surgical treatment, if it's combined with Clean&Seal, we get clinical benefits of up to 1 millimeter, which is quite a big difference. And we could see that the pocket closure rate is approximately 2 times higher compared to the control group. For the surgical, we have been discussing it now only with one case in the end, but I can tell you there are already quite some studies showing that it probably has a similar good effect as animal matrix derivatives. And for the non-surgical, as well as for the surgical, there are histological studies giving us the proof that higher than PG is causing periodontal regeneration. And then I can give you a last tip if you want to read more in detail about the story about hyaluronic acid. There's one article in the Periodontology 2000 from Professor Piloni, which gives really a nice overview on the topic. With that, I would like to thank you for your attention, and I hope I could give you some nice tips on a Wednesday evening, and I look forward to your questions.
Grazie Cristina, thanks for the presentation e grazie per aver fatto una combo tra parte scientifica e parte, come dire, clinica. Sono già entrate 3 domande. Cristina, there are three questions when your presentation. The first question is, when you apply the hyaluronic acid, in which phase?
I couldn't hear the last part of your... When I apply hyaluronic...
in which phase you apply hyaluronic acid?
You mean in which step of treatment?
Yes.
I mostly use it in step 3. So most of the times I do a standard step 2 therapy. So really just subgingival instrumentation without any adjuncts, because as I've shown you, one can treat or one can solve a lot of the sides just with the subgingival instrumentation. And then I prefer to use the adjuncts like the Clean&Seal concept in the step 3 therapy for the residual pockets, or in step 4 if I have a recurrent pocket.
Perfetto, because I link with another question che hanno domandato se si può usare solo nelle tasche residue. So, if Clean&Seal you can use only in the residual pocket or also in step 2.
You can also use it in step 2. So the indication is basically the same. So for example, this first RCT from Egli-Ramanos-Kaite, which I have shown you, where I've shown you this 1 millimeter difference, that was a study which was done in patients in step 2 therapy. So you can use it in both. I personally prefer the approach to do the standard treatment, because one really can solve many of the sides just with the subgeneric instrumentation and then use it in step 3. But you can definitely use it in both steps. So if you have a patient who is super motivated and wants to do all the best what is possible, it is a possibility to use it also in step 2, definitely.
Perfetto, passo con l'altra domanda. I give you the other question, che ogni quanto ripeti il trattamento Clean and Seal? Cioè, how many time you repeat the Clean and Seal cycle? You say 2 time, but
I would say for periodontitis cases, in most of the cases, you can fix it with 1 round. But there might be some cases where you need a second round. If you make a small side step to periodontitis, they are more often need a second round. But in periodontitis, most of the residual pockets you can fix with 1 round. But
Ok.
as I've shown the one case, it might be sometimes necessary to make a second round in the next supportive care.
E aggiungo questa domanda che mi chiedono tipicamente. I had this question that is from my side. È
Mhm.
dopo quanto decidi di ripetere il ciclo? Cioè, after how many months you decide to repeat the cycle after you do the first time?
So most of the times, like this one case, what I have shown you, which are patients which are actually already going under supportive periodontal care, then I book them after 3 months again. So
Ok.
often in the beginning, I keep them a bit shorter than after 3 months, and then I decide whether it's necessary to do a second round or not. So I do not book them earlier or more often for supportive care.
Ok. Another question, un'altra domanda. How is the behavior of the patient? Cioè, qual è il comportamento del paziente dopo la terapia?
How is that?
Yes, the behavior of the patients when you.
I most of the time tell them, so immediately after I've applied the hyaluronic, I tell them just to spit and not to rinse for 1-2 hours, so that they do not rinse it away. And then I most of the time tell them not to use the interdental brush on the same day in the evening, but from the next day as normal.
Perfetto. E another question, un'altra domanda. Perché il protocollo Clean&Seal non va utilizzato in associazione di clexidina? So, why the Clean&Seal protocol is not recommended to use with chlorhexidine?
The reason why, so the reason is basically the perisolve, because as I told you, the perisolve is sodium hypochlorite, and you should not, what we know also from the endodontic treatment, you should not mix sodium hypochlorite with chlorhexidine because it might make small crystals. So that means when you put the perisolve into the pocket, you should not rinse with chlorhexidine. So you should just rinse, as I said, either you just use the ultrasonic and go around, or you use saline solution and rinse it. After you have removed the perisolve, there is basically no real contraindication for chlorhexidine. So it's just a combination perisolve and chlorhexidine, which should not be mixed. But on the other side, we also know that the patients do not need to rinse after this treatment at home with chlorhexidine. So there's not any real additional benefit of it. But what's, from a chemical point of view, should be prevented, that you mix the perisolve with the chlorhexidine.
Perfetto. Another, but un'altra domanda, che se ci sono studi sulla stabilità del risultato nel tempo, if there are study of the result of stability on the time, during the time.
So you mean how long the effect of the treatment could last?
No, I think that if there is a study, I think the RCT that you showed with we have a long timing of result, so maybe 9 months is the more.
The one in the step 3, what I've showed you, have been 9 months. And then basically, I mean, if we achieve one's pocket closure in a periodontitis patient, if the patient comes then regularly to the supportive care and keeps up a good oral hygiene, it's seldom that they get again a recurrent pocket on the same side, because if the pocket is once closed and then the patient comes regularly, I do not see a problem that it's not kept on a longer time point. But the studies which are available are between 9 and 12 months.
Perfect. Un'altra domanda, se può essere utilizzato su pazienti con parodontite generalizzata, if Clean&Seal can be used in patients with periodontitis generalized in the mouth.
You can, that would be basically if you would use it in step 2 therapy. So if you use it really in all the sites, you mean that?
See, when you have a patient with generalized periodontitis,
So as I said before, so you can use it in step 2, you can use it in step 3. Is a little bit up to you to decide. I sometimes, at least also with the patients in Sweden, I have the problem that it's always a little bit of a discussion also on the financial part. And then I prefer to do first the standard treatment where they do not have to pay extra for the adjuncts,
Okay.
and then focus with the adjuncts on the residual pockets. But there's nothing, absolutely nothing against using it in step 2 therapy.
Okay.
But if you use it, for example, if you have really generalized, you might need, for example, two perisolve, if it's really one for the upper jaw and one for the lower jaw. Because with one, it's getting tight to really manage a generalized case, let's say it like that. With the higher dent, easily have enough.
Yes, thanks a lot. Qualcuno chiede la differenza tra Perisolve e la polvere di glicina, quindi L4. Somebody asked about the difference against Perisolve and L-Flow power, so glicina, glycine power.
It is, as I have not heard that it is a problem. And we are using the Clean&Seal concept also in the perimplantitis treatment. And for perimplantitis, I use a lot the air polishing, and we also use the erythritol powder. And we have also not seen any problem there. So I don't think that the concentration in the powder is so high that it really makes a problem. I have not heard it, and I have not seen it.
Or if the result that you achieve with Perisolve is the same that you achieve with Power, cioè se il
You mean
risultato...
the comparison?
Sì.
No, I mean, if I use it, so for periodontitis, if I do the re-instrumentation, I'm more focused on ultrasonic and hand instrumentation, and not so much on the air polishing. So there I mostly use ultrasonic and hand instruments. If I go to perimplantitis, I use a lot the air polishing, but then I actually combine it, because then my treatment approach looks like that I do first the air polishing, and then I start with the perisolve and the instrumentation with titanium curettes, and then the higher dent in the end. So I do not really compare it from that aspect.
Questa come dire, si collega a un'altra domanda e la tua esperienza in caso di perimpantiti is linked to another question that your experience in cases, perimplantitis cases with Clean&Seal.
My experience in periodontitis cases is that I really can manage more cases non-surgically, and especially cases which have maybe 20% of bone loss, 25, maybe maximum 30% of bone loss. So where you have some bone loss, but not those cases with 60, 70% bone loss. But the ones with beginning bone loss, let's say up to 1/3, one can manage quite nicely with the non-surgical approach. But to my experience, for the perimplantitis, I often need 2 rounds.
Ok, sempre dopo 3 mesi, after 3 months with
2 to 3 months, I would say.
Ok. Another question, un'altra domanda. Quando decidi di fare il secondo ciclo, in base a cosa? Cioè, sorry. Based on what do you decide to do a second cycle?
If there's still so if I still have a deep pocket, so 5 millimeters or more, and if I still have bleeding on probing.
Ok.
So basically, if I do not achieve pocket closure.
Ok.
Pocket closure would be defined as 5 millimeters without bleeding on probing.
Perfect. I will do the last 3 question because time is finished. Farò le ultime 3 domande. La prima, ho una domanda sulla recessione, se possiamo utilizzarla nella copertura delle recessioni. Aveva chiesto about recession, if we can use it during recovering recession.
There are clinical studies as well as histological studies which have proven that it gives a nice additional benefit in addition to, so for example, if you do a corneal advanced flap with the hyaluronic, you get better results compared to the corneal advanced flap only. And there are also histological studies which have shown quite a nice periodontal regeneration to some extent.
Sì, c'è uno studio there is a study on Antosculian sul
Mm.
tunnel technique e una di Pilloni sul CAF con comparazione aciuronico con Endogain. Quindi ci sono questi due studi sulle recessioni. The second question, can we do a bone graft along with this protocol?
Definitely. I mean, I've shown you now only one case very quickly in the end, a surgical case. But in general, the principle how I use Hyadent in surgical periodontitis cases is the same as I have been using Emdogain before. So if I have a well-contained defect with free walls, I only use the gel. But if I have a defect which is not so well contained, maybe it has only 1.5 walls or 2 walls, then I combine the Hyadent with a bone substitute. So basically, I use it exactly in the same way and in the same indications as I used the Emdogain before, depending on the defect configuration.
Ok. The last question, l'ultima domanda. La leggo in italiano e poi in inglese. Quanto incide nel risultato finale riuscire a preservare il cemento radicolare durante la strumentazione manuale e meccanica? How is the impact of the final result to preserve the cementum, radicular cementum, during the instrumentation?
I would not know now that there's any study really assessing whether you get a better preservation of the cementum. And what you can see is, for example, the one study which I've shown you with this preclinical study, that you, even with a non-surgical approach, can achieve periodontal regeneration, which is including new cementum and new attachment. The preserving of the cementum, I think, is also a lot depending on how we instrument. So I would not know now that Hyadent really preserves it better, but it can cause new cementum or it can lead to new cementum. Say it like that.
Perfetto. Grazie a tutti. Io, the time is finished, quindi il tempo è finito. Ringrazio i partecipanti che sono stati tanti. E I thank to you, Cristina, that you're very. I would like to bring you in this webinar perché you're very efficacy in mixing clinical and scientific. And so, grazie a tutti e spero di rivedere presto Cristina. I hope to see you in Italy also early. And manderò a tutti i partecipanti il registratore del webinar se voleste vederla. E niente, quindi per chi vuole siamo a Milano, abbiamo uno study club sempre sul trattamento Clean&Seal mercoledì prossimo. E niente, vi teniamo aggiornati su tutte le attività che faremo. Grazie Cristina e ringrazio anche la traduttrice che ora è in una sala e thanks also to Cristina Bonani that is our translator and thanks to all for your time. Grazie a tutti per il vostro tempo.
Thanks for the invitation. Have a nice evening.